Hello. Welcome, everybody. We're going to be looking at a case recently of a shoulder injury and a very high-level injury at that. So I'm excited to be able to share this with you and to be able to talk about cases that are going to require maybe some longer-term maintenance intervention. And one of the things that I've been working on, thanks to you joining me in these webinars, and particularly the case studies, is really refining the way that the interaction of the, more importantly, the continuum of care as Pilates teachers, and thinking of what do we do as Pilates teachers when somebody comes to us. How do we screen them? What algorithms do we use? How do we determine if they need to go see a doctor or a physical therapist? If we're a physical therapist, how do we then continue their care sometimes with prehab, if it's before surgery, sending them to a Pilates teacher, or post-rehab after discharge. And even at times, I like to use my fellow Pilates teachers in the middle of rehab. Like, for example, because I run a cash pay clinic, I try to keep it as affordable as possible, with the greatest bang for the buck, as we would say. So if somebody comes to me, I might see them once a month or twice a month and have them work with a skilled Pilates teacher 2-3 times a week, or taking a class for healthy spine 3 times a week, 4 times a week, is going to have a better outcome than passive intervention in some cases 2-3 times a week at a much more expensive cost. So as we talk about this, we go through these case studies, I want you to think about, where do you fit in? Where do you fit into that spectrum? Where do you see yourself? In this particular case today, we're going to be talking about Fred, who's a 41-year-old police officer, and he also is a mixed martial arts practitioner. So he's very active, he's very strong, he is in great shape. If you're familiar with ever working with police officers, my father was a police officer. There's some I was going to say ego, but it's not. I mean, you could call it ego, but they're just a confidence and an air, and it's really important by who they are that they can perform and practice and do all the things that we expect to do as servants in the community. Anyway, Fred's a 41-year-old police officer. He came to me with a primary complaint of left shoulder pain after he was training in mixed martial arts. And so he felt a pop and some severe burning in his shoulder. He noted that he was not able to lift his arm up over his shoulder height, and that's where he presented. He saw a physician right after me that he had scheduled. I helped him control some of the pain. He was able to get an MRI of that shoulder. We continue with his physical therapy, which I'll be going through sort of step by step. But where I really want to get to today is this idea of Fred's need for continued care, for his ability to have the continued strength that he's going to need to be able to get back into the ring with the mixed martial arts, and also to perform well in his job. Let's go to the next slide. So here we have in his patient interview, as we do with all of our clients, asking him, what do we believe you are not able to do that you believe you should be able to do? And the main thing that he complained about was lifting his arms overhead and lifting greater than 50 pounds for him to be able to work and also to be able to recreate. That if he wasn't able to do that, when we look at our ICF model, he couldn't return to work and he couldn't recreate, which are 2 things very important to him, let alone just in his daily activities. He couldn't lift his arms, so he was not able to get his shirt on easily, he was not able to wash his hair easily, et cetera, et cetera. And when I asked him, Fred, what do you believe prevents you from participating in these activities? He, in his mind and in his belief, is that he tore something in his shoulder, and I have weakness and sharp pain every time I lift my arm. So he has completely aligned the pop sound that he heard when he was practicing and working out in the mixed martial arts to the pain, and also to what I'm going to show you came back as a result from the MRI. And these things all are going to contribute to what Fred sees as contributing to his pain, right? And we talked in depth about pain not long ago, and it's important for us to always sort of keep that in mind of what people believe. So let's take a look at his objective assessment. The MRI showed an incomplete tear of the infraspinatus tendon and the bicep tendon, and also what the surgeon called a non-surgical labral tear. Now, the labrum is what sort of deepens the socket of the fossa to be able to make a socket for the head of the humerus. Remember, in the shoulder, this particular capsule joint is quite loose compared to the other ball and socket joint in our body, which is the femur and the hip. And what he did, if you notice up on top in the red circle, that's the bicep tendon coming into the labrum. And a lot of times when the bicep tendon has a small tear, it will also cause a small tear of the labrum. And it's called a slap lesion or a slap tear. And that's what we're dealing with Fred. Now, the surgeon felt it was non-surgical and felt that with rest and physical therapy that he would return to his normal function. So his first visit in physical therapy, active range of motion, that's what AROM stands for, active range of motion. In his left shoulder, he was not able to flex his arm up past the height of his shoulder. We call it 80 degrees approximately. And that was secondary to pain. So when I did the passive range of motion, he had full range of motion. That's me moving his arm through space, full range of motion. I'm just showing you things that were limited. But flexion, 80 degrees, abduction out to the side, 65 degrees with pain, external rotation, 45 degrees, not too much pain, but internal rotation, putting the arm in, did reproduce that pain again about 45 degrees. When we look at power and what's called the manual muscle test, that's him being able to resist pressure. Now, remember, he's a strong guy. I wouldn't want to take him on the street or in a ring. He's a very young, strong, buff kind of guy. And yet his shoulder was what we call 3+ out of 5 in flexion, abduction, and external rotation. So what that tells me is that he has strength, which means it's not a complete tear of the rotator cuff, but it's limited and barely able to lift up against gravity. Tells me that it's a 3+ out of 5. 3 means that he cannot lift it against gravity. 3+ he can lift it against gravity. And the other thing to remember here is that the primary limitation that he observes is pain. So remember when the MRI, the magnetic resonance, showed that Fred did not have a complete tear. It was a partial tear, partial thickness. So that means that it's going to heal up, it's going to scar down, it's going to do its normal thing, and it's going to get better, right? Now, if he gets too aggressive on it too fast, he could re-tear the tendon. If he doesn't do enough on it, the tendon won't be strong enough for when he returns to mixed martial arts activity, okay? So again, weak power in abduction, flexion, and external rotation. And we know that, he has the problem with the bicep, he has a problem with the infraspinatus, and he has a problem with the labral, the slap tear where the bicep tendon comes in, are the 3 lesions that he's dealing with. Okay, so that's how he presented himself when he came to me for his physical therapy. Let's go to the next slide. So we did physical therapy with him. His physical therapy consisted of a lot of assistive work using the Pilates equipment, using the tower bar sprung from above, using a ball at home that he could move up and down against the wall. We did little tiny oscillations. His strength started returning very quickly. We were very gentle in the beginning, gradually getting a little more aggressive. By the time we got to 4 weeks, his flexion was at 170 degrees. His abduction was 170 degrees, almost all the way up over him. And if you compared it to his right side was also about 170 degrees. A lot of times we think that 180 degrees is normal. That's desirable, especially in mixed martial arts, but he was pretty robust up in the shoulders, and 170 degrees was his normal. External rotation, 90 degrees normal. Internal rotation, 75, still a little limited. We like to see it at 90. And his shoulder abduction, flexion, and external rotation strength had increased to a solid 4, which means he could move his arm through that space. He still had a little bit of a painful arc when he'd go through the 90-degree motion. He'd have a little bit of pain here, and then he'd be able to go up past it without any discomfort or pain. And that's quite common in shoulder pathologies. So as we look at his case, what I'm thinking now is I would really like him to be working with a Pilates teacher now. I'd like him to be working on some private training, and to be able to continue to get him built up to where he's a 5 out of 5, that he's able to do these advanced moves and weight bearing that he would have to do both as a police officer, maybe restraining somebody, maybe climbing a fence, and then definitely in the mixed martial arts. If you've watched any MMA, you know what they're being submitted to. And again, these types of injuries are not uncommon. The good news, partial, incomplete, it's going to heal up. It's already healing 4 weeks out. He's already got some good healing going on. But we want to continue to work on grading that load and getting him back to where he could tolerate some of the advanced loads that are going to be placed on that arm and on that shoulder. I have a comment from Sarah. Sarah, good as always to hear from you. It says, hello, presume a complete tear would require surgical intervention. Thanks, Brent. And that's a great point to bring up, Sarah. A lot of times there are complete tears that actually heal up on their own, that do exist, that are considered complete tears. But typically, if you are athletic or you are very active and young and you have a complete tear, the surgeon's going to want to do a repair on it. And that would be an arthroscopic procedure, typically, where they would go in and basically sew down and tighten up that rotator cuff tendon. So here's our first question. So again, we're looking at Fred 4 weeks out. He's done real well with his rehabilitation, and he's coming to us as Pilates teachers now. So before we assess him based on the information, so I'm the therapist, I call you up and I'm like, hey, Sarah, hey, Angela, hey, Anna, hey, Ashley. I got a client that is doing really well with his physical therapy. I want him to start doing his Pilates 3 days a week with you. I'm sending him over. Here's some information I have on him. And now what I'm asking you to do is say, based on what I just told you up to this point, what would you, as a practitioner, hypothesize that Fred needs the most right now from a Pilates teacher? This is very important that we understand this continuum of care. I'm going to keep driving this home in the future workshops. And if you're a physical therapist, same thing. Thinking of you as a physical therapist are prescribing this to somebody, to a Pilates teacher. What is it that you are expecting or hypothesizing that Fred needs at this stage of the game? He's 4 weeks out. He's maybe 70% healed up. He needs continued load. We know what he needs to do. We haven't done any testing on him yet as a Pilates teacher. What is it that we want the Pilates program to do for him? What does Fred need to focus on? So while you're answering that, something that I've been working on and mentioned is this idea that we have sort of it's our Polestar structure of how we think and problem solve. So somebody comes in to see the Pilates teacher, and you know how we've worked through the principles of movement, and we've worked through the ICF model, or the International Classification of Function model. And we ask the question, how do we know what we're looking at, right? So when we ask that question, what do you believe you should be participating in? In Fred's case, he wants to participate in his mixed martial arts, and he wants to be fully capable of doing his job requirements, which are very stringent, and they have to test every year. They have to test that they're capable of things like climbing fences, pulling people out of cars, restraining, other things that they have to do as part of their training. and mixed martial arts, of course, we talked about already. So we know that's his goal. That's where he sees himself. That's where he was before the injury. That's how he got injured. And now he wants to go back there. So we have to identify which areas of functional movement or activities are limited, what test will tell us if he's ready to go back, and then prescribing Pilates exercises and home programs to help him achieve that. So let's go ahead and bring up the screen, Melissa. Let's see what people are saying. By the way, I mentioned that we're 100 people on the screen and I only see 13 answers up here. This is fully interactive. Please get into the menti.com that's up on the screen, and that way we can have a lot more activity. So I'm looking at some people looking here: shoulder girdle mobilization and stabilization, continued range of mobility, chest extension or thoracic extension, good. Full range of motion without pain and strength is absolutely necessary for him. Improved range of motion, flexibility. We're on that goalpost test we're going to come back to in just a minute. Pick out these gentle Pilates movements that do not aggravate the injury. Good. So we're thinking of that idea of how do we create positive movement experiences that can allow the scarring that's needed to happen without it being restrictive or adverse in the future. Progressive strengthening, mobility, full body interaction, full body integration, all exercises focus on shoulder mobility. So I think we're in the right direction here. Nothing in here jumps out at me as not being a great idea. Let's go to the next slide. So let's go now, and we talk about our functional test again. I probably should get in the habit of throwing up some of Polestar's functional test up here, but if you've gone through Polestar's training, we have what we call our screening, the Polestar screening, and we also have our Polestar assessment tool. We use these tests to be able to see how people are going to do with their Pilates exercise and also with the activities that they have chosen to participate in. So this is where, for example, the goalpost that was mentioned in the last question answer would be an appropriate answer here. You can put more than one in, but the idea is picking which of the functional tests would you want to do. So for example, in the past, we've done things like squatting and lunges and those things for lower extremity injuries. What kind of things do we want to test or look at for upper extremity injuries that would represent the activity limitation that Fred has, right? So we know what he wants to do. We know what that activity is. We know he has to be able to have his arm back. He has to have the strength. He has to be able to pull and push and lift and climb. So what tests, and it doesn't have to be a Polestar test, but what test or functional test would you want to see him do to be able to determine where he is compared to where he needs to go? So take a little bit of time here and answer those questions on your Mentimeter. Make it a lot easier for us. All right, so we know goalpost is a biggie for shoulder girdle. I see flexion, prone, chest rotation, prone extension, press up, very good. Shoulder flexion, test of shoulder range of motion. I love that you are putting in thoracic extension and chest extension into the discussion. Sometimes we get caught up when we think of just the shoulder joint. I also think it's important that we think of the scapulothoracic and the thoracolumbar, looking at the movement that's involved in almost all of our movements. So a lot of times, decreased thoracic mobility is going to lead to hypermobility or instability of the shoulder girdle, the neck, and the lumbar spine. So that's why we put so much emphasis in Polestar Pilates on being able to restore thoracic mobility, and not just in extension. And in his case, we want to know it also in rotation. We want to know it in side bending. We want to be able to see all planes of movement in that thoracic spine, and also make sure that he has the motor control of it. If you think of the scapulothoracic region of the body, the scapula sits on top of the thoracic, and it's not really a joint. It's like a plate, the omoplato they call it, like in Spanish, but that plate sits on top of the rib cage and it glides, and it's tethered in different directions. Well, wherever that scapula is, as we've discussed in the past, is going to be preparing for the congruency of the head of the humerus as we move the arm. So in Fred's case, this is crucial that Fred has a restoration of thoracic mobility and scapulothoracic control. So it's not just the mobility, but it's also the control. All right, these look awesome. Let's go to the next slide. So these are some of the ones that I did with Fred. I wanted to know that thoracic mobility. So I did seated rotation and side bending. I looked at some prone press up. I looked at goalpost. Goalpost tells us so much information. I see that Angela Rice put up hands behind head and hands behind back. And that's a great test we use in physical therapy just to look at function of that shoulder. And he certainly could not do that in the beginning, and he was still limited a little bit on that in the end. And then I thought that I would put something like side lift and push up in the battery of tests, because with his mixed martial arts, he's a jiu-jitsu practitioner and does trains with a Brazilian jiu-jitsu master up here in North Carolina. And if he doesn't have the ability to do push-ups and side lifts and things that would maybe take him into advanced side kick and snake and twist and some of these advanced exercises, he can't get back on the mat. He can't get in the cage. That would be a real mess. All right, so we're all on the right track. Things that I found for him: his seated rotation was a little limited, and that had nothing to do with the injury. I should say it could be a problem that led to the injury. It will be a problem in him healing and returning to those activities if we don't restore thoracic mobility. So that became a big high priority for me in his Pilates training. Goalpost also, we were able to get, he had the 90 degrees and was able to get his arms up after. So he was almost clear. I would say he was about 80-90% clear on a goalpost, and obviously more limited on the left side than the right. So there was some asymmetry. Side lift, he still couldn't tolerate the side lift on the left. He had no problems on the right. And a push-up he was able to do without a problem. So his triceps and his strength for a push-up, very easy for him. It also built a little confidence for him to realize that he's not broken the way that he'd been thinking for the last 4 weeks. The side lift, he realized he did not have that abduction, congruency in the shoulder or in the thoracic to be able to bear that weight. I have another comment from Sarah Edwards. Potentially, comment might have been his lack of thoracic mobility and congruency of the joint that initiated the injury in the first place. Just thinking out loud, and you're thinking very accurately that it's not. I often don't like to use a cause and effect, but there is a correlation. And we also know that in the healing part of it, the correlation of thoracic mobility and shoulder mobility. If the thoracic is really restricted or a little kyphotic and restricted, then you're going to have a lot of anterior displacement of the head of the humerus in the joint. And that's going to cause things like slap lesions and tendon breakdown. It's going to cause supraspinatus problems, subacromial problems, all related to lack of thoracic mobility, especially with people who are using their arms in advanced movement, right? Anybody using their hands over their head. Another comment from Sarah Tyndall said scapular mobility, pec, lats, rhomboid restrictions, lower trap, serratus weakness can also be a limiting factor at end of ranges. And we saw that, right? And that's what we were mentioning is we saw that his scapula was not having normal mobility and gliding on that thoracic cage, which means that it's going to put extra stress on the glenohumeral joint. And those are things that we want to work with. So great point, Sarah and Sarah. And good things coming forward. Let's move forward. So your turn again. What principles of movement would you prioritize for Fred? So this one, I think you can do more than one if you want. But as you go in there, pretty straightforward. You understand the principles of movement, of breath, of mobility, of control, of alignment, and movement integration. So as you look at those, just identify where, based on what we just said, based on what we were just doing, what do you think would be the priority? And again, you're picking, they're all important, but where would you start? What do you think is going to be an area that Fred needs first and foremost? And, the way I sort of think of this sometimes is, look, we're moving the whole body. So we identified that Fred had some thoracic limitation in mobility, some tightness around the scapulothoracic region with, the trapezius, the rhomboids, the serratus anterior. Excuse me. And we identified that he still has some inflammation and some healing going on. He definitely doesn't, we don't want to take him to end of ranges so much. So as we think of that, what is it that we want to restore in Fred's program with us as Pilates teachers? And Melissa, let's go ahead and open that up. We got a lot of activity on this one. Let's see what people are saying. I love the fact that you're balanced between a lot of mobility and control. I see more people hanging out in mobility. I think they're both like right there. I would be hard pressed. I almost would lean a little bit more towards control, only in the sense that he already is getting pretty good range of motion. So I'd want to see, can I challenge him to control that? Remember, he was a 4 out of 5. His passive range of motion was pretty full. He was able to lift his arm up, but he had a painful arc. So when you have a painful arc, I also look at alignment, right? So alignment meaning congruence is, are we able to keep that congruence of the head of the humerus with the shoulder? That means that the scapula has to be dynamic to maintain that congruency. And then also that ties into movement integration, which is coordination. It's not a mobility issue. So let's back out of this a little bit and talk about this. If I was going through and I was using my Polestar algorithm principles, the first thing I would do is say, did he lose alignment or not? Dynamic alignment. So we said that he did lose some dynamic alignment in goalpost, and we said he also couldn't manage it in side lift, right, with the left arm. So the next question I would have is, if I gave him tactile verbal cueing or imagery and he corrected, then that tells me that he needs to work more on awareness to be able to maintain dynamic alignment of that shoulder. But if the cueing didn't make a difference, then I would look at control. So maybe I need to modify the load. Maybe I need to create some assistance. And if he was able to improve that by modifying the load and have better dynamic alignment in the shoulder, like a tower bar or a ball up against the wall or the foot bar and a closed chain activity like quadruped, all of those could tell me that lightening the load or decreasing the effect of gravity could be what's needed to focus on in the treatment. So a graded load approach would be important for him. And if we still saw that he was restricted, like he still had the movement impairment, and it didn't change with cueing, it didn't change with modifying the load, then we can think pretty clearly that he still needs some mobility training. So that could be myofascial release, it could be joint mob, it could be thoracic manipulation, it could be some gentle stretching, it could be just allowing the tissues to heal if they're hypermobile. So the way that's sort of the way I look at it. So let me repeat that again. We go from looking at the dynamic alignment in our test, and we see that they are not able to maintain that dynamic alignment. We then look at coordination or movement integration by cueing them, things we do best, right? I'm trying to think of this from my Pilates eyes, not my PT eyes. And I look at them in coordination. So I'm asking them, what happens if you send your shoulder in this direction? What happens if you control it from this way, or push into my hand a little bit, or feel the shoulders doing this, right? We can give them a tactile cueing, and it corrects. That tells me that it's not a mobility or control issue. That tells me it's a coordination issue. And we're just going to practice until they're able to participate correctly without having any kind of faulty movement alignment. Then if that doesn't change it, then we go to the next one, which is control. And in control, as I mentioned, we're going to modify the load. And if we modify the load and the dynamic alignment improves, then we know that we need to approach it with a graded load approach, which is what we do in Pilates. So the first two tests, the first two attempts to correct with the principles are 100% in the scope of a Pilates teacher. There's nobody better, I think, even in anywhere in movement science, of re-educating movement and facilitating graded load than what we do in the Pilates environment. And then if those don't seem to allow them to correct the dynamic alignment, then we're looking at mobility. And mobility might mean that it needs to go back to the physical therapist or work in conjunction with a physical therapist or be patient until the mobility is restored before we would start working more on the coordination and control. All right, let's go to the next slide. That was great, you guys. So let's go right into exercises. So we're about 40 minutes in. What exercises would you incorporate for Fred's Pilates program today? What would that look like? And we've already mentioned some of these things, like what we're looking whole body exercise. We've talked about decreased thoracic mobility, a little bit of kyphosis, a little bit of limitation in the scapular mobility. We know that we want to maintain congruency. He has pretty much full range of motion passively. He has a painful arc. Here's another clue for you. Closed chain activities are going to give more proprioception feedback into his body than open chain. And yet the majority of upper extremity activities are open chain. So if we think of progressing his exercises from a closed chain environment and moving him towards an open chain environment would also be important in your prescription of exercises. So whole body, whole Pilates repertoire, special focus on probably for him a little bit more of control. So we have a graded load, a little more focus on his consciousness or awareness. So the cues that we use are really important. And we're probably going to go from closed chain activity towards more open chain activity. Even though as a mixed martial artist, he has to do a lot of closed chain activity on his upper extremities. So take a moment, fill in those answers and see what you think and think about it. And you can put in more than one. So if you get through one and you think that was a good one, but you want to do something else, feel free to do that. All right. Well, I've missed doing some of the case studies. We have a lot of interesting interviews coming up the rest of the month. We have one with Eric Franklin. A lot of you know Eric. Eric is going to be joining me May 12th, I believe. We have other great leaders in our profession of movement that are going to be with us coming up through this month. So stay tuned as we bring them to you. I believe this is going to be my only case study this month, unless I slip one more in towards the end of May. So something to think about. All right, let's see what people are saying. What are your programs looking like? Good. So pseudo chain exercise, closed chain exercises. That'd be like things like tower bar. It would be things like the pedal of the chair is a great one. Starting to work with, proning and coming up into swan using the chair. Push through variations on the Cadillac. Arm springs are going to be a pseudo open. So you're sort of guided with the spring tension. Great. Pulling straps, kneeling arms. Yeah, seeing some good variations coming in. Long stretch chest expansion with rotation, the swan. Love it. Scapular series, seated pull down on the trapeze, quadruped, exercise in the mat and reformer. Good, because we want to make sure they can do things at home. And do write things in here as well that they can do at home. Remember, we record these sessions and send them back to you. So if there's something you miss in it, you can certainly take notes again on your own time when it comes to you on Friday or Saturday. Standing arm series on the Cadillac is great. Standing on unstable surfaces. right? So it could be on a Bosu ball upside down, or it could be on a wobble board and doing all of the arm arcs and exercise arm circles on the trapeze table. Excellent. Really good ideas in here. Scarecrow. Very good. Upstretch. I can't tell you how important, I think whoever put upstretch in there, give yourself 2 thumbs up. Upstretch on the reformer really is where the whole body is moving around the glenohumeral joint. So the thoracic, the scapula, everything has to move around the glenohumeral joint in a loaded closed chain position. So that's a great way to build confidence. If Fred could feel that he could do some of these exercises you're suggesting, it's going to take him over the top. I saw somebody put a lot of rowing exercises in there. I think that's a great idea. We just have to be careful and make sure that we're not aggravating anything. So the rowing exercises might come in a week or 2, or as he tolerates it. So again, the orientation of the body in the rowing experience. Remember, the only place he really has pain is at that 90-degree mark. So what would happen if we were doing the rowing in a little bit more of like 110 degrees or down low with the flexed arms? Could also be a good way to go. Again, if you have any questions, make sure that you ask inside the Q&A. Is the easiest place for me to follow as we're going through this. And super happy with these exercises. You guys are awesome. Anybody want a job? I'm hiring. Come find me. All right, so summary of Fred's case. And I think we have a good idea on what's happening here. But from a diagnosis standpoint, he had a partial tear, so it wasn't complete. It's going to heal up in the rotator cuff and also in the labrum. The labrum is a little trickier. One of the key things we want to remember if we ever have patients with labral tears, if they didn't get repaired, they're at risk of tearing a little bit more. It's like the meniscus in the knee or the labrum in the hip or the disc in the spine. The more abnormal load that goes through that tissue could lead to more trauma to that tissue or more damage. So the best way we protect the labrum is by maintaining congruence in that joint. And that's alignment. And we're the specialist of alignment. How do we maintain alignment in the shoulder joint? Well, that's typically through the thoracic and the scapula. So one of the things I want you to take home from today's discussion is we really have to get his thoracic mobility and scapular control, that's a neuromuscular control, to be able to ultimately manage congruence between the scapula and the head of the humerus. And if we can do that, we're going to minimize the likelihood of degeneration and other problems with the labrum. If they go back to whether he's in a kyphotic position, his shoulder comes forward, now when that arm gets pulled, it's going to cause more problems on that labrum. He can do more damage to it. He needs to understand that risk, right? His level of participation is super, super high. That's really important for us to know and just to remember. We don't need to baby Fred at all, but we also want him to respect the injury that he has. And then we look at our goals, and he has no intention of not returning to these activities, both his work and his recreation. And the plan I put down here, a lot of you address this very clearly with your exercises: increase awareness, mobility, control of shoulder girdle, both closed and open chain activities. So you guys really rocked it today. I have Elise from Brazil as our licensee and just a beautiful Pilates teacher. And I thought it'd be great because we have a few minutes left if she wants to join and maybe discuss with me a little bit and share her viewpoint on how she would work with somebody like me as a physiotherapist in being able to exchange and collaborate with our clients in this kind of a setting.
Hi, let me turn on the lights here. I wasn't prepared to be on.
This was not set up ahead of time, so this is completely random. But thanks, Elise. If I see, Dan, you got to always wonder, I might catch some of you on there and bring you on. So Elise is one of our most beautiful creative movers in the Polestar family, and a dancer, creative, choreographer extraordinaire, loves props. Looking at this case, Elise, from your perspective, if I presented this case to you and I said, Elise, I need your help. I want you to work with this person. They're healing well. Everything's good, super athletic. Brazilian jiu-jitsu is his thing. So it's like, Elise's from Brazil. So not that she does Brazilian jiu-jitsu,
No,
but we've done some capoeira. So, there all there's some things in common. Anyway, what would you think? Like, what are some things that came to your mind while we were, working through this case and some of the other people that were putting their comments up there so eloquently?
I work a lot by intuition. So, and by looking at what's going on and maybe getting feedback from how he felt on the moves. So I think I would explore possibilities of movement in the most possible different ways, especially because fighting, dancing, and doing high-level sports, you can be caught up in a position you didn't expect. And I think Pilates is great, but it has some very square possibilities.
Yeah.
And if we could expand that to different angles and qualities of motion, and
it's important that you bring that up, Elise, because when I talked to the way that I met Fred was through his mixed martial art instructor, and he called me up and he goes, "Oh my gosh, I hurt this cop that was taking class from me, and I feel really bad." But as we were talking, he said the thing is that he was inexperienced in some of the abnormal ranges of motion. He was used to like going to the gym and pumping weights and everything in the sagittal plane or the coronal plane. And what you just brought up was really crucial because, for him to go back to mixed martial arts, it's not about the sagittal plane. It's not about the coronal plane. It's about this just complex, like you said, intuitive exploration of movement. And he's just, the thing about mixed martial arts is about submission, right? So they put people into positions and they crank on their arm or their leg or their head until they submit. So the ones who do the best are the ones that have incredible suppleness and really understand intuitively congruency. They're able to get into weird positions and still keep their joint intact so it doesn't dislocate. When we feel it's going to dislocate, what the trainer said is he tried to fight it. He tried to get out of the position, and that's where he did the tear and heard the pop, where if he would have gone into it. So if you look at the really good mixed martial artists, and this is true with any of us in dance and movement that has multiplanar, is how do we integrate the joints? So thinking of that, what are some tips that you could give to the people online as to how you would explore that? Like, how does your mind, you're so beautiful at being able to, explore, there's not a hard rule. Movement is in very complex planes in normal human movement. What are some things that, just even the ways you look at it or would test it to see how he's doing?
I'm in love with the walls. So I like pushing wall. And I think you can gradually increase, and it's a good thing because he can take home. And gradually, as you go away from the wall, the load increases, and also the range in the elbow. So playing with pushing the wall, I actually posted a little video on my Instagram.
I saw one of it was like a concrete thing that you did a whole.
It's a rock. Yeah, I'm in a rock. Yeah, and it's like playing with different pushes and pulls, positions of the wrist, the hand, shoulder out of the congruency. And because sometimes we work, when we were working in a safe environment, we think of congruency, but life is out of congruency. I'm not, reaching for something with my shoulder in place. I'm going to go there. And the same thing when we fall, you fall and then your shoulder goes out of the congruency place. So to to play with less load. So against the wall is great, maybe on the table, and different shoulder arm positions, and including your spine, and especially feet on the floor, because then you connect everything to the tensegrity system and the center. So standing work, that's why I like the wall, because you are really using the whole body connected and connecting everything to the center. And
I like the idea of tapping into the tensegrity model, that the whole idea of equal tensions and unequal tensions communicating to each other. And if we become aware of that, I think that'd be another great tool of just having the consciousness, like you're talking about, of what does it feel like when your heels are down and your head's up and your arms are pushing in a different direction. Like, what's the feedback? We know that our feet represent the largest part of our brain in the sensory cortex. That's where, we have, if you look at the homunculus in the sensory cortex, the foot is the biggest part of it, and then the hands, the lips, and the genitals, in that order. Some people might have more in the genitals than others, I don't know, but the feet are the biggest, feet and lips. So that's really important. As Ido Portal, we've talked about this, Juan Nieto is a huge fan of that movement and that play exploration. And that's what they do a lot of, right? Juan talks a lot about this, of how do you move your tissues into planes and loads that are not what we would call congruent or in alignment. And how do we do that to make sure that we have that coordination in and out of congruency? So, for example, taking the knee out of alignment, taking the toes out and the wrist and the hands out of alignment and moving through those. And one of the things we know is about tissue adaptation. So tissues adapt to load. So that's why I was impressed with what you were doing with the stone the other day, is just creating like different load positions on the hands, the arms, the elbows, the ranges of motion that would be perfect for somebody like Fred. Like, that's what he needs. He has a very immature, he's very strong, very buff, very aggressive, but he has a very immature sort of proprioception and awareness of his body out of the normal, planes of movement. Yeah. Any other thoughts?
No, I think to let him take, like you taught me, Brent, the responsibility over his pain and his limits, and make sure he's attentive at the moment of doing it, so that he doesn't go over the place. But he has to explore. He has to explore his own limits. It's not me that's going to tell him where he has to go, but he has to explore in alignment, out of alignment. If he falls back someday, how would he be able to catch himself? And smaller ranges of motion to big ones, less weight to more weight, progress. And like you said, including different planes of movement, using the whole body as much as possible, integrating. So first just the arms, positions, then arms and spine, and then pelvis and feet, and things like that.
Yeah. And it's nice, and again, you do this so well. Anybody who is interested in following Elise in her post and her social media, she's always showing very creative ways with the equipment and props, and more importantly, things that people have access to. I think this is really important, that what do they have at home? What can they do on the floor? What can they do on an uneven surface? What can they do with the wall? What can they do in the water? Anything that we can use that people already have access to be able to do this. And I'll come back to it over and over again. Joseph Pilates says, that if we practice contrology every day of our life, there would be no need for prisons, insane asylums, or hospitals. And I am convinced, I wasn't there when he said this, but I'm convinced that he did not intend for us to see a Pilates teacher every day of our life. He wanted us to practice contrology, which is what we're talking about. If any of you have any last minute questions before we close down today, we got through the case pretty quickly. Alicia, I appreciate you coming on impromptu.
Thank you.
But I remember once upon a time, I was down in Brazil and Alicia convinced me to dance in the impromptu concert.
Ouch.
I don't know if
Sorry.
you remember that.
I certainly do. Never forget that.
Talking about labrums. But anyway, it was a great experience.
Yeah.
There's a question, there's two comments here. One is from Christine. She says, I have integrated fascia fitness in my Pilates classes with great results in decreasing pain. I think that's great. I think that, we're going to see more and more knowledge coming to us. It's not that we don't integrate things. It's not that we don't explore more. I think it's just understanding where things come from and be able to say, this is Pilates with combined with this, or this is me bringing in some myofascial work, or me bringing in some Feldenkrais work, or movement exploration. So great work, Christine. And then let's see, I have, is that Manya?
Brent?
Manya, yeah.
I thought of one thing too, like regarding what she just said, is like the qualities of movement too. Bounces, swings, release, throw. I mean, at some point he's going to have to start not doing only controlled but movements that are more like real life.
Yeah, so that is that progression, that open chain and acceleration, deceleration, tempo changes. Too often we get stuck in our Pilates mindset of everything slow and controlled. And like one of my favorite exercises is bent knee openings, but I like to do it as fast as people walk in the door.
Yeah, it's great that.
And as soon as you make it fast, it's a completely different exercise. And yet it is what most closely reflects a rotational force in walking. That's what comes close, or running, right? There's a comment here from Maya. She says, hi, Brent, curious about the position you are hiring for. Yeah, write to me, Manya, and let me know. Brent at Polestar Pilates. We'll talk. And then fascial fitness. I am assuming, I am not trained in fascial fitness, but I'm assuming that it is looking at an integration of myofascial work, which is very popular now. We can find it with everything. And being able to think of movement as its effect on the fascial system, and vice versa, the fascial system's effect on movement. And if you think of how the myofascial system works, to me, the easiest way of thinking of it, and Alicia mentioned it with the tensegrity, right? Tensegrity is how the fascia that connects everything, our organs, our bones, our muscles, our skin, the brain, the nervous system, everything is connected by the fascial system. And the tensegrity is the integrity of tissue, or the balance of tissue in response to load or lack of load. So when we're moving, does the movement rely on things like elasticity? So for example, somebody who has very good alignment and form in their running is so balanced in their tensegrity that they don't have to use a whole lot of muscle strength. Their energy is much lower, and yet they are performing at very high levels, and it's almost more of an elastic property. People that are bouncy, people that jump, people that are springy in martial arts and dance, those are often, tensegrity working at its best. And so I'm assuming, and I could be corrected by Christine at any time, but that is tying the myofascial system as the focus of the exercise. A couple of things I see here, spontaneous movement training, and that's our game. So we always want to create spontaneous movement. And remember, in motor learning, we go from a declarative learning state. Declarative learning is where we have to be conscious. We have to be aware of what we're doing. That can be the slow movement that we do so well in Pilates. But then it has to go into practice or procedural learning. And we talk about this in our progression, our principles of going from unconsciously incompetent. We don't know what we don't know. We become conscious and aware that we're not very competent. We don't move very well. We don't like to stay there very long at all. And then we go into conscious competence. And conscious competence is a shift from external feedback, that's us vomiting all of our cues and tactile cues onto the client, to an internal feedback where the client's going, I feel that. I feel better when my pelvis is in this position than in this position. Or I notice more power when my body weight is forward 2 degrees. And they start having this consciousness. Now, the practice of that is the only thing that takes it to subconscious or spontaneous. And so that they have to be doing all the time in their life. It can't be in our clinic. It can't be in our studios. That has to be, and somebody the other day on one of our webinars, I think with Shelley, had made mention that it wasn't really Pilates if it wasn't with a certified Pilates teacher in person. It was like, we know that's not true anymore. We know that's not true. If people are practicing what we teach them, they are practicing Pilates in their homes, at work, in their chairs, wherever they are. If they're moving and they're practicing consciousness and awareness that they experienced in our studio or in our classes or online with us, they're practicing Pilates and they're going to get those benefits. Listen, we're out of time. Elise, thank you so much.
Thank you,
Appreciate your work. You're doing some things. Talk a little bit about just what you're doing these days. What are some areas that you are putting focus or developing new courses or new content? I think I saw some things with the centipede being revitalized a little bit. Talk a little bit about what you're working on these days.
Yeah, I love props because people can have at home, and I like that idea. I think Joseph Pilates is right. We should incorporate that in our life, and having at home, it's really nice. And I've been teaching online now since the pandemic started, and so I'm playing with Fly Moon, which is a project that changed the baby arc into the up position, so it balances. It's a new project. And then also the foam roller from Feldenkrais that I like very much. It's more like motor controlled and muscle strengthening, and I love that. Also Centipede, like you said, that by Isabella Moody. It's wonderful because you are massaging your body at the same time you're challenging yourself. You can do Pilates on it, you can do other things.
I use the Centipede every single morning.
Me too.
I get off my bike, I go lay down on it, kneel on it, stand on it, roll on it, change the orientation every morning. It saves my back and my knees, but I get on it every day. That's one of my favorite props.
It's a delicious one. I go every night before I go to sleep. Just to,
I think you sleep on a whole mattress of centipedes.
I'm playing tennis ball, over ball, and things like that. But my classes are in Portuguese, so. But I would love to teach some classes in English too, maybe.
Well, we just have to make that happen. I was going to say that I mentioned Eric Franklin's going to be on the 12th. I have Pam Downey that's going to be joining me for some pelvic floor and continence work. I have Peggy Roller, who wrote the study with Don Marie Ikes on falls and fall prevention. So she's going to join me. And I have Adrian Lowe, who is the king of pain. He's going to talk all things pain with me coming up in June. So we got some dynamo webinars coming up. Share them with your friends. We'd love to get this out. It's free. We love people to learn. We like to learn with you. And we will see you next week. Remember that today is a good day to be good. Be kind, be gentle, have hope that there is peace in the world. Keep sharing it, keep praying for it. Be that kindness, and we'll see you next week. Thank you, Elise.
Thank you, Brent.